Start it, sir.
ഇനി അങ്ങനെ അങ്ങ് പോട്ടെ, ഇനിയിപ്പോ അധികം ശ്രമിക്കണ്ട, പോട്ടെ മുമ്പോട്ട് പോട്ടെ.
ഫാക്കൽറ്റി ജോയിൻ ചെയ്തിട്ടുണ്ടോ?
ജോയിൻ ചെയ്തിട്ടുണ്ട്.
സഞ്ജയ് സാറിനെ കാണുന്നുണ്ട്, പക്ഷേ
രണ്ടുപേരില്ലേ?
സഞ്ജയ് ഇതിനിടയില്
എന്റെ ശബ്ദം കേൾക്കുന്നില്ലേ ഡോക്ടർ ഡേവിഡ്സൺ?
ഡേവിഡ്സൺ ഉണ്ട്.
കേൾക്കുന്നുണ്ടോ സാർ?
കേൾക്കുന്നുണ്ട്.
ഓക്കെ സാർ.
കണ്ടിന്യൂ ചെയ്യാം.
Sir, start ചെയ്തോട്ടെ.
സ്റ്റാർട്ട് ചെയ്യും അഞ്ജലി.
യെസ്.
Okay, sir. Good evening all. Myself Dr. Anjali, junior resident from Jubilee Mission Medical College. Today I'll be presenting a CNS case. Presenting a case of a 10-year-old girl hailing from Edapal, informed his mother, reliable. She came with a chief complaint of pain in both upper limbs since the morning of 4/8/2025, weakness in both upper and lower limbs since morning of 4/8/2025. History of presenting illness. An apparently normal girl initially presented with pain in both upper limbs around 7 a.m. on 4/8/2025. Pain was initially over right upper limb. Sudden onset, dull aching started over shoulder region, gradually progressed to involve the whole right upper limb. No aggravating factors. Within half an hour, she developed a similar kind of pain over left upper limb involving the whole limb. About 1.5 hours later, child developed difficulty in holding pen with her right hand. Soon after 1 hour, she was unable to hold a mug using right and left hand and could not raise arm above head while bathing. By that time, pain in both limbs subsided spontaneously. Concerned about her symptoms, parents decided to take her to a local hospital at around 10 a.m. However, she was unable to get up from bed on her own. Initially, she could walk with support from parents, but gradually she became unable to walk at all, and buckling of knee was present. Also, there was difficulty to wear chappal as she was not able to grip the chappal properly. Weakness was more pronounced in left lower limb. As a result, parents had to rely on wheelchair to carry her. By 12:30 p.m., she was unable to sit on the wheelchair, so she was shifted onto a structure.
Anjali, I'll stop you there. I want to know your thought process. Okay, that's a timeline that you have.
Yes, sir.
You want to explain the timeline?
Yes, sir. The child, after waking up, she noticed there was a pain over her right shoulder initially around 7 a.m. Then, within a half an hour, the pain was also present in left shoulder, and she was trying to write. By 8:30 a.m., when she tried to hold the pen, she was not able to hold the pen with her right hand. And then she came back home and she was trying to take bath, but she was not able to hold mug with right and left hand, and also not able to raise arm above head. And around 10 a.m., she was unable to get up from lying down position. And around 11 a.m., she was unable to walk. And 12:30 p.m., she was even unable to sit on wheelchair, so was put on stretcher.
So I want to know your thought process in this. How are you going to analyze this case step by step? Right from the first symptom.
Here the first symptom was pain. That too, the pain was started over the right shoulder. It shows the involvement of sensory system. Then
what was the character of the pain? How did it migrate? That's all very important.
Yes, sir. I asked about the character. The character was dull aching type of pain. And she just remember only the pain started over the right shoulder and then migrated it to the right whole upper limb. And then the pain was migrated to the left upper limb also. She was unable to tell in which area, whether medial or lateral. She was unable to recollect that incident.
So you have a sensory symptom, the right shoulder, and then involving the whole right hand. And
Yes,
meanwhile, while it was involving the whole right hand, it migrated onto the opposite side.
Yes,
and
sir.
then it is involving the opposite whole upper limb together.
Yes, sir. Yes, sir.
So when you say from the shoulder and it is descending down the whole upper limb, that means there is a migration.
Yes, sir.
Okay, so probably you have a there is a system, and there are multiple segments being
Yes,
involved.
sir. Yes, sir.
Probably these are the assumptions. And did you ask about hot and cold sensation during this time?
Yes, sir. I asked whether she was able to feel the warmness or coldness of the water while taking bath, while touching the water. She told that she was able to perceive that. And I asked
Okay, so
whether she
there
was
is a
able.
sensory. Yes, tell me.
So,
Go on. Please go on.
and I asked whether she was able to feel the touch of her mother, and she was able to feel whether the cloth was touching to her upper limbs. She was able to
Okay,
perceive
that's
all
very
this.
good. So very good. So you have a sensory system involvement. Now, what is that characteristic term that would you ask? There is migration from one shoulder to another side and the whole involvement. Is there any term that you want to ask? Usually, it's more of a theory, but we could ask whilst asking a symptom. A band-like sensation. Was there a
Band
band-like
like sensation.
sensation?
No,
Band-like
sir.
sensation.
No.
So that was not there. Okay. And now we know that it has started somewhere in the shoulder. So
Yes, sir.
shoulder, it is somewhere in the C5. When you tell shoulder, you will think probably C5, arm abduction, and it is descending down. It has crossed the midline onto the
Yes,
opposite
sir.
and it is descending.
Arishi,
Probably.
okay?
Okay, this is just probably. And then there is involvement of the whole limbs. First the
Yes,
upper limb and the trunk and the lower limb. So again, the weakness is descending. So I want, as a PG, I want to uh, ask you what are the questions that you're going to ask for distal weakness, proximal weakness of upper limb, lower limb. I'm sure that you have written it. This is
yes,
before you tell the history. How are you going to ask upper limb, lower limb, proximal, distal weakness, including trunk? What are the history that you want to
upper
ask?
limb, upper limb distal. I will ask for whether she's able to write. She's able to button the shirt, or uh, she's able to hold things. And proximal group, I'll ask whether she can raise her arm above head. And lower
Okay.
limb distal, I will ask for whether she's able to wear chappal.
I'll, I'll pause you on that. So distal, yes, buttoning, unbuttoning, writing, like tearing a chapati, breaking an idli, opening the cap of a bottle,
Yes, sir.
opening the door, closing the door. That's
Yes,
all
sir.
important. Tying a shoelace, fine movements, writing. And proximal, yes, putting on the sleeves, combing the hair. That's very important. Okay.
Yes, sir.
So next, low limb, what all will you ask?
Lower limb, I'll ask for whether she's able to wear chappal for distal group.
Yes. You're wearing a chappal, then low limb distal, proximal.
Proximal, I will ask for whether she's able to stand from a sitting position, and she's able to
Okay.
climb stair.
Yes. Putting on chappal. Now this child probably has a sensory component. Now putting on chappal, will you want to differentiate between uh, problem of sensory slippage or motor problem? Can you differentiate that?
Yes, sir. Uh, I asked her whether she noticed the slipping of chappal, and she told she was able to feel that chapel was slipping. So there was no sensory component
Okay.
involved.
So when there is, you put the chappal, you walk, and then there is slippage of chappal with notice. That means the toes you're not able to grip the chappal.
Yes, sir.
And the chappal we mean that means a Hawaii chappal. Normal Hawaii chappal, not the one with the back strap.
Yes, sir.
So if you are able to grip and
And
walk and it slips off, you're not able to grip properly and slips off with notice. With notice is the most important thing. That means it's a distal weakness. It's a motor weakness. If the chapel slips off without notice, you take a few steps, and after a couple of steps, you notice that on one leg there is no chapel, and chapel is behind you, and you have not noticed. That means it is a sensory involvement because the chapel has slipped off, you have not noticed. That is slippage of chapel without notice. That means there is a sensory problem.
sensory.
Okay. Then how will you ask for the history of truncal weakness?
Truncal muscle, I will ask whether she was able to get up from bed, from supine position to sitting, and whether she is
Usually, how do
able
we
to
get
sit,
up? Yes, tell me.
whether she was able to sit, maintain the sitting posture,
Yes, maintaining a sitting posture.
and
So,
also, yes, sir,
yes, tell me.
and also respiratory. Also, I'll ask breathing
Okay,
difficulty.
respiratory involved. Yes, that is also important. That respiratory part you could ask separate set of questions. Now, how do you think a child will be getting up?
Sorry, sir.
How do you think a child will be just getting up?
After the
When the
weakness
child gets up, no. For a normal person, how do you
for
think
a
the child
normal
is going
child.
to get up? Yes. And how do you know whether there is weakness or not? That's what I want you to understand if there is weakness or not through history. How do you think what you'll be asking to look for the truncal weakness? What history are you going to ask? Yes, if the child able to get up. Suppose there is not a significant weakness, some maybe 30 percentage of weakness is only there. How do you think the child is going to get up? Normal
There,
versus abnormal.
okay. When the if in a normal child, uh, the child first uses the leg, lower limb over the floor,
Kutti കിടക്കാണ്
then
കുട്ടി straight on the bed. Child is
on the
just lying
spine
down on
position.
the bed. On the bed,
Okay.
child has to get up. Okay, I'll make it
So
clear.
first,
It is a
she
big bed, you have to get up.
okay, sir. So first,
ഞാൻ ചോദിക്കുന്നത് നേരെയാണോ കിടക്കുന്നത് ചെരിഞ്ഞാണോ? Will the child
Nere,
just get up straight or child will tilt and get up?
child tilt.
In what situation?
So
So if child is lying down, if there is no weakness, child will get up like this and then get turn, turn and come out. But if there is weakness, child will turn to one side and get up. You understand?
yes, sir. Yes,
Because
sir.
your trunk weakness is there. Child will
Yes, sir.
use the hands to push the body
Yes,
against
sir.
gravity and lift. Okay, child will not. So these are very important. So I'm sure you would have brought that in the history. So you have a sensory component, probably not very sure, and there is a, is it a ascending or a descending weakness?
Descending.
It's a descending weakness, and patient is quadriparetic within 5
Yes, sir.
hours,
Yes, sir.
involving upper limb and lower limb.
Yes,
Okay.
sir.
How bad was the weakness?
It's a sudden
When I say
onset.
how bad was this, yes, how bad is the weakness in terms of was the child able to move the hands at the at the highest weakness of the illness was when the child came to the casualty. Definitely, child is in a stretcher.
Yes, sir.
What was the maximum weakness by history? I mean to ask whether the child was able to move the fingers. Was the child was able to move the hands above the body, or child was just lying down like that, straight, without any movements? Was there any finger movements? That's what I mean. Was there
No, sir.
anything like that? So probably it's grade 1 or 0 power.
Yes, sir.
So why do you think that is very important?
Um,
It's very
distal muscle
important
to
because
distal to
it's very
proximal.
important. It's, yeah, it's proximal. It's from upper part from the shoulder region descending down very fast,
Yes, sir.
and child is being caught. We need to look at the respiratory compromise. We'll come to that later. Okay, so you can continue. You may continue.
Okay, sir. Okay.
Did you understand the
Yes,
thought
sir.
process? So you have a
Yes, sir.
sensory
Yes, sir.
component.
Yes, sir.
There is a motor weakness,
And it
and it is
migrated.
descending down. It is
Yes, sir.
descending down. All right. Please tell.
Okay, sir. Coming to negative history, no history of altered sensorium, abnormal behavior, seizures. No history of stiffness of limbs. No
I
history of
want you to
dizziness,
tell. I want you to tell. I want you to give explanation of each of your negative history. I want you to tell what is your thought process behind writing every negative history.
Okay, sir.
So what's your
Uh,
justification for that?
okay, sir. No history of altered sensorium, abnormal behavior to rule out encephalopathy, seizures to rule out increased intracranial tension. No history of stiffness of limbs to rule out UMN spasticity. No history of dizziness, palpitation, and increased sweating to rule out autonomic dysfunction. No history of anosmia, drooping of eyelid, restriction of eye movement, double vision to rule out cranial nerve involvement. No history of slurring of speech, difficulty in chewing food, drooling of saliva, cranial nerve involvement. No history of difficulty in swallowing food, hoarseness of voice, nasal twang of voice, bulbar palsy. No history of involuntary movement, abnormal eye movement, cerebellar sign. No history, no difficulty to perceive pain and temperature, decreased sensation over limbs. Sensory, no history of difficulty in breathing and complete sentences, diaphragm muscle, no history of neck pain. No history of fever with rash, to rule out viral infections such as enterovirus, Coxsackie. No history of any bite such as a dog bite or a snake bite. No history of recent vaccination such as influenza, MMR, DPT. No history of drug intake such as Davison, isoniazid, acid, chemotherapy. No history of toxin intake such as botulinum, organophosphorus. No history of intake of canned food to rule out botulinum toxin. No history of trauma. No history of throat pain, swelling of neck to rule out diphtheria. No history of joint pain to rule out SLE type vasculitis. Oral ulcers to rule out Behcet disease. No history of abdominal pain with psychiatric manifestation to rule out porphyria. No history of recent travel to rule out paralysis or polio. No history of recent upper GI or viral respiratory infection to rule out GBS. No history of weight loss, night sweat to rule out carcinoma and TB.
All right. Very good. I would appreciate that. So, history wise, can you tell each cranial nerves and what are the history? I know you have written down all the negative history in this. So, in this history, you have brought out beautifully how the cranial nerve and the autonomic system is not involved.
Yes, sir.
So, can you tell again in this child, what particular history you will be really fascinated for
Uh,
involvement?
bulbar palsy,
Yes. So, what are the histories in bulbar palsy?
Difficulty in swallowing food, hoarseness of voice, nasal twang.
Yes. Swallowing, can you be more specific? Swallowing for solids, liquids? Can you bring that up?
Liquids.
Yes, liquids. Now, why liquids then solids?
Uh,
Mostly, mostly for a neurological problem, the first symptom, first for a bulbar neurological bulbar involvement, it will be regurgitation. It
yes.
will be for liquids. It will need be because solids is a solid thing. It will just follow down. But liquids, it's a well coordinated neuromuscular synchrony that has to happen. So when that even a mild asynchrony is there, you will have nasal regurgitation. So you will have difficulty for liquids first. Okay,
Okay.
so when there is liquid, always think of a neurological problem. And of course, nasal tang of voice. Then what are the other things that you ask for this child? Which, as a doctor, is very important for a sudden onset quadriparetic child in the casualty, which was descending.
Autonomic dysfunction.
Yes, what all other symptoms that will you ask for autonomic dysfunction or look for?
Dizziness, palpitation, flushing, increased sweating.
Yes, yes, very good. Then respiratory compromise, what will you ask? What is through history that you will get about a respiratory compromise in this child through history?
She was whether she was able to complete sentence
Okay, good.
and about breathing difficulty.
Okay, all right. Shortness of breath. Shortness of breath. Okay, some breathing difficulty is there, probably. Yes. Then,
Whether she is able to complete sentences,
yes, you said it.
speech,
You should ask for
able
the
to.
cough.
Yes, sir. Cough reflex.
Cough is very important.
Yes, sir.
What happens in cough?
Cough reflex
Just
will be
what is
absent.
cough? What is your understanding of cough? In cough, what happens? There is a sudden partial closure of our
The vocal.
larynx because of the approximation of the vocal cord. So there's partial closure, and then
Again,
there is sudden lift of the diaphragm, contraction of the intercostals, increase in the intrathoracic pressure and the lung, and there is sudden burst.
ex- uh,
Yes, correct. Sudden gush of air through a narrow space. So what happens whereas larynx is not able to approximate, the vocal cord is not able to approximate, you'll not able to cough. That is one thing. That is one thing. Second thing, if the diaphragm or the intercostals is not able to bring up that intrathoracic pressure, so again the cough will be affected. So cough is, you can look at the function of the diaphragm and the vocal cord, the larynx involvement in this. Why we are very worried about this is because the shoulder is affected. Shoulder is C5, and the phrenic
yes, sir.
nerve also has the same root value.
C3 to C5.
So this is very important in history taking to have a idea of, because a child sudden comes and you look at this child and these are the first things you should ask for. Okay,
Yes, sir.
good. Next. So now, what do you think? What do you think?
From
is the
collecting the net.
localization. The localization. Localization. How will you localize? Now let's come to the localization.
Okay, sir. It is most probably LMN lesion.
No, I want you to think from the brain. Can you tell me
Okay.
which all is there from the brain until the muscle? Can you track the structures from the brain to the muscle grossly, just basic?
Okay, sir. Uh, Brain, spinal cord. In spinal cord, we have gray matter. From gray matter,
Brain,
anterior horn
brainstem,
cell,
spinal cord. Yeah, spinal cord, anterior horn cell. Tell me.
anterior horn cell,
Yes, anterior horn cell. From spinal cord, what comes out? Nerve roots comes
spinal
out.
nerve, spinal nerve,
Nerve roots.
neuromuscular junction,
Yeah. So nerve
and muscle.
roots, then
Yes,
nerve roots, then nerve
nerve, neuromuscular junction, and
junction.
finally muscle.
Yes, neuromuscular junction, muscle, and probably some channels in the muscle. We could take it like that. So let me ask you: is it the brain that is involved here?
No,
Is it a problem of the brain? Can you tell why? Why it is not the brain?
cranial nerves are spared.
Brain or brainstem?
Both brain and brainstem is spared, sir.
Why? Can you tell me why through history?
Uh, Brainstem, those cranial nerves arising from brainstem spared, sir.
Okay. Okay. So cranial nerve involvement is not there. Then
And there is no feature of raised ICP.
okay. Then
There is no spasticity.
when there is acute neurological involvement, the chances of spasticity is very less. This is acute presentation.
Okay, sir.
I want to tell whether it will be symmetric weakness or asymmetric weakness. Point one first. Will it be symmetric or asymmetric weakness? What do you think, Anjali?
If brain is involved, sir is asking about brain involvement.
Whether it's brain or brainstem, the
Will be
weakness will be
asymmetrical.
symmetric. Pardon?
Asymmetric.
So asymmetric. That is the main important thing. Do we have asymmetric weakness here?
Uh, Almost symmetrical, sir.
So like both the
Yes,
limbs
sir.
are involved together. Like just
Yes, sir.
imagine if something should go wrong in the brain to produce bilateral upper limb weakness, the patient will be very bad state. Okay, because both the brain should be involved. Okay, so that is not happening here. It's only
Yes.
it's the patient has come in quadriplegia state to us. So that's why it's not the cerebrum.
Yes, sir.
Okay. Next, brainstem also. If the brainstem, you'll have element signs ipsilateral to that, and you'll have contralateral weakness.
Yes, sir.
So that's why it is not brainstem. Now it is spinal cord that we have. Can it be spinal cord?
Pardon, sir.
Can it be a spinal cord problem?
Uh, yes, sir.
Why do you think it is a spinal cord problem?
Because here we have both motor and sensory symptoms.
Okay, motor and sensory symptoms. Yes. Okay, it's a spinal cord problem. Then It is like probably like a transverse myelitis, complete transection. Probably. Or, okay, so it could be a spinal cord problem. It could be any of the spinal cord problems. It could be anything. You could come to the differentials later. So, spinal cord, probably. So, can it be nerve root?
Nerve root, if it is involved, there will be shooting type of pain.
And it will be one side, it will be shooting
Yes.
pain. Like the classical example is sciatica.
Sciatica.
Okay, so less likely to be nerve root. Can it be nerves?
Neuropathy, usually it begins in the proximal.
Neuropathy, proximal.
No, sir, distal, distal.
Okay, good. So neuropathy is always distal weakness.
Yes, sir, distal.
Okay, did this child have a distal weakness or a proximal
Yes,
weakness to
distal
begin with?
first.
Okay, okay. So what neuropathy could do you think can produce something like this? Acute onset, descending, quadriparetic.
Compression.
The compression will be okay. Compression of nerve. We are talking about nerve, Anjali. We are talking only about nerve. Is there any nerve problem that can produce like this?
Sir,
What is a nerve problem that can present like a quadriparetic state?
okay, got it.
For nerve compression, if you tell it is nerve compression, then
Only
it is only
simple.
one nerve, right?
Yes, sir. Yes, sir.
Like a
Yes.
carpal tunnel syndrome or
Yes, sir. Yes.
Saturday night palsy, where a drunkard is there and you have a radial nerve weakness. So it is GBS.
Yes, sir.
Guillain-Barré syndrome is a demyelinating polyneuropathy. It is demyelinating. So possible of a nerve like that. Now, can it be so? Nerve, can it be neuromuscular junction problem?
Yes, sir.
Neuromuscular junction problem, usually it is chronic. There will be a past history. Classical example is a myasthenia.
Yes, sir.
Okay, unless they come in a crisis. Okay, usually they'll be having a past history and it will be slowly progressive or sudden deterioration. Do they have a past history of any neuromuscular problem?
No, sir.
We have not come to the past history. Okay, it can be neuromuscular junction, myasthenia if it is a sudden crisis, myasthenia crisis. Can it be a muscle problem?
Muscular, mainly motor symptoms, sir.
Yes, motor system. So can it be a myopathy? Myopathy, we could keep it
Yes,
down
sir.
because usually they'll be having some symptoms. This neuromuscular junction and myopathy, unless there is sudden deterioration, they will never be quadriparetic like this. So unless you have a past history of some myositis or some muscular dystrophy with some onset of infection or something, they do not worsen like this. So as of now, the child did not have any fever.
No.
Okay. Now, so neuromuscular junction is over, muscle is over. Now, can it be any channelopathies in the muscle itself? Some channelopathies, can it be?
There is no triggering factors.
I'm just asking the differentials.
Hypokalemic periodic paralysis.
So, hypokalemic periodic paralysis. So, what is the history that you have in hypokalemic periodic paralysis?
Uh, Excessive carbohydrate intake. Increase
Yes,
exercise.
yes. So, that is one history. So, that because it is a pure motor symptom, we should think in terms sensory probably plus or minus. We don't know.
Yes.
We think it is there, but patient does not tell about any sensory loss anywhere through history. So predominantly we have a motor syndrome which is descending and making the child quadriplegic. So you told about tick paralysis, very good. Tick also produces motor symptoms. Then diphtheria and the botulinum toxin. Okay. So this is the way you think. So it is not, so we know by history that it is not the cerebrum or it is not the brainstem that is being affected. We know it is somewhere from the spinal cord down.
Yes, sir.
So, so where do you think from the spinal cord down it will be?
It can be from.
I want to tell whether it's the cervical or thoracic or lumbar. You tell me that.
Okay, sir. Cervical,
Yes, cervical, because it started from the shoulder. Your
shoulder.
brachial plexus
Yes, sir.
comes from the cervical, right?
Cervical.
So your hand is being affected first. So it is cervical. Somewhere in the spinal cord, cervical. It's not thoracic because it was the hands that was affected. Okay? Did you understand
Yes, sir.
why
Yes,
we
sir.
are localizing in the spinal cord and from where we are localizing
Yes, sir.
through your history alone? In neurology, history is the boss.
Yes, sir.
Okay, so we'll go to the next. Does any of the sirs want to comment on the history or give some opinion, please?
Well discussed, Davidson and Anjali. Anjali,
Yes, sir.
Dr. Davidson was discussing the complaints, the systematic manner to answer whether there is a neurological problem, where is the lesion, and what is the pathological basis. For all neurological conditions, it's like that.
Yes, sir.
So first question is unlikely to be a functional situation. There is a neurological problem. And then most likely the evolution of the problem is very important. There was a sensory problem.
Yes.
It
Yes, sir.
started in a manner very interestingly, right side, then the left side, then the evolution of any of the problems, a pain, a sensory problem or weakness, it's important because at the end, the anatomical localization, whether it is in the radicals or spinal cord, there are a few very interesting neurological spinal cord problems where the evolution in that pattern will be helpful. It can be there are different types: right shoulder, right upper limb, left upper limb, then the left lower limb, then the right that pattern, and there are different patterns. That is very important. So there was a sensory problem in the initial, and how long it lasted, whether there was a sensory problem in the lower limb, you didn't mention that. So transient sensory problem was there, that was there only in the upper limb. So just
Yes,
like
sir.
any pain, you need to ask about the provoking factors, relieving factors, because in the situation, there are two types of sensory things, that a positive thing or a negative thing. So it was a pain situation. In the pain situation, spinal cord, it's a funicular type of pain sensation, radicular type of pain sensation. There are three types. What is aggravating? The Lhermitte sign like situation. So the movement of the short, the neck or the limbs, what happens? So aggravating and relieving factors are important. So in this case, the transient only. After that, sensory part was not too much.
Yes. Yes, sir.
Later, there itself, the important thing is the bowel and bladder. I think you didn't give too much importance for that. In any of the situations, bowel and bladder is very important because the main differentiation is between the radicals and the spinal cord here. So the bladder involvement is a little more in depth of the bladder involvement, whether he's perceiving the bladder problem, whether he's able to initiate, whether he had to complete, all sort of the neurological evaluation of the bladder part in a 10-year-old child. that is possible, and that's very helpful to differentiate the type of the involvement of a spinal cord, whether it is a compression from outside, intradural, extra parenchymal, intraparenchymal, and there again there are different patterns. So the history part is so important in the analysis. The basic two things, there is a sensory and there is a major weakness that is progressing, and very fast, within a matter of hours it is evolving. So both for the anatomical localization and the pathological basis, these are very important. In the negative point history, that's where I want to tell. Now I am going to mention about the negative history. That's not a good thing. Negative histories are to be utilized for your localization or pathological thing. So all the negative points you are coming for the pathological analysis should be later, and the negative points will be helpful. The anatomical localization should come in the initial part. So we are considering the where is the lesion part in the initial thing. So for that, the negative points which are relevant at that time should be finished, and the rest of the thing is basically for the type of pathology. So that should be very important. You have finished the history part. Past history is completely normal child, or you're going to that immunization and the family history and the other things are you are yet to come. Okay, sure. This is enough, Davidson.
Yes, sir.
Uh, can I continue, sir?
Yeah, continue, Anjali.
Hello? Hello?
Sanjeev, parayyu.
There was a problem. Good evening, sir. There was a problem in joining. I was able to hear, but I was not able to join. Now I think it is rectified by our PGs. Okay, Anjali, go on, continue. She is explaining nicely. Okay, right. Can you hear?
Yes, sir.
Can you hear me?
Yes, sir. Yes, sir.
Yes, sir.
Okay. Proceed. Right.
Past history, no history of previous hospital admission, not on any regular medication, no history of TB contact. Antenatal, natal, and postnatal.
In the past history again, the purpose of the past history, Davidson was mentioning,
Yes,
very
sir.
useful for anatomical localization also.
Yes,
In the
sir.
past history, few of the metabolic problems, channelopathies, neuromuscular junction and all, it cannot be an all of a sudden presentation of this quadriplegia. So that's a very important thing. Whether there was a similar problem in a subtle manner or a serious manner, when there is a triggering factors are helpful for few of the pathological basis. Okay. Then again, lot of entities are relevant in a neurological conditions, which may be arguing for the pathological problems. History of tuberculosis, history of drugs, any food-related heavy metal poisoning. So many of the rarer situations also that also need to be included, because in a condition which is evolving over a few hours, you need to consider vascular
Yes, sir.
problems
I
in a
asked it in
spinal
the.
cord. Look off here, Geeta, ഞാൻ ചീത്ത പറയേ Geeta. പിന്നെ ഗീത കേൾക്കുന്നുമില്ല, ഓണാക്കിട്ട് പോയിരിക്കാം. എന്തേലും പറഞ്ഞത് പറഞ്ഞെല്ലാം
So vascular problem.
In a case of vascular, because when it is evolving over few hours, you need to consider vascular problems. So there are spinal cord problems like anterior spinal cord artery. ആ സിറ്റുവേഷൻ്റെ അകത്ത് പാസ്റ്റ് ഹിസ്റ്ററിൻ്റെ അകത്തും വാസ്കുലറിന്റെ ക്ലൂസ് ഒക്കെ അതിൻ്റെ അകത്ത് വരേണ്ടതുണ്ട്. ഓക്കെ, യു ഗോ അഹെഡ്.
Okay, sir. Antenatal, natal, and postnatal history, there is nothing significant, sir. Should I elaborate?
You can skip that.
Sir?
You can skip that. You can skip that.
Okay, sir. Okay. Development history. She attained milestones in all 4 domains at appropriate age. She is studying in 6th standard with good scholastic performance and fair relationship. On the day of admission, child is dependent on mother's support for all basic activities of daily life. Dietary history. There is excess of 60 kilocalorie energy and protein. There is excess of 16 gram. She is taking sufficient amount of fruits and vegetables which are rich in micronutrients. She is consuming mixed diet. Immunization history, immunized for age according to national immunization schedule. No optional vaccine taken. No adverse event following immunization. BCG scar present. Family history, there is no history of neurological disorder in family, no hemorrhagic thrombotic rheumatological disorders, no history of similar illness in the family members. Socioeconomic status, she belongs to upper middle class according to modified Sumi classification. Summary, 10-year-old girl with normal development and immunized up to age with normal perinatal dietary and family history presented with complaints of sudden onset of pain in both upper limbs and weakness of both upper limb. The weakness was progressive asymmetrical in beginning to almost symmetrical later, involving bilateral lower limb and truncal muscles without bowel or bladder, respiratory and cranial nerve involvement.
Okay, fine. Continue.
Okay, sir. Differential diagnosis, GBS probably descending, demyelination, group of disorders such as transverse myelitis, MOGAD, neuromyelitis optica spectrum disorder, multiple sclerosis, vascular like spinal cord ischemia, bleeding into a spinal cord tumor, vasculitis such as SLE, BSET, channelopathy such as hypokalemic periodic paralysis, congenital such as AV malformation.
All right. So you should, in certain things, like GBS, when you say, would you like to elaborate? Why did you tell all these? Because you localize to the spinal cord, the neuromuscular system, where the GBS nerve and nerve root is affected. It's the motor system. And the can you tell me two acute neurological problems that can present like this? What are the acute neurological problems that present like this?
Um,
In general, there is a sudden weakness for a person. What are the two neurological things that will you think of in general?
vascular,
Yes, vascular. Second,
um, demyelination.
demyelination. These are the two things that you should always think. Okay, so when you tell AV malformation, where is the AV malformation? Where is the AV malformation? When you tell AV malformation, where do you think it is a AV malformation? It is in the cervical spine.
Yes, sir.
Okay, arteriovenous fistula malformation in the cervical area.
Yes, sir.
Okay, somewhere in the thoracic area will not produce a weakness of the hand.
Sir, okay, yes, sir.
Okay, and if it is a spinal cord bleeding into the spinal cord, you should always ask whether there was dragging of legs or some weakness of the hands or decreased dexterity of the fingers. Because whenever the spinal cord is very tight, so unless it is a very slow growing tumor, you will definitely have a weakness. If it is a very slow growing weakness, the body will adapt. The body will adapt and the weakness will not be very overtly seen. But child will tell that the handwriting change is there, playing the piano or eating things, small dexterity. If the child is a dancer, മുദ്രകൾ കറക്റ്റായിട്ട് പിടിക്കാൻ പറ്റിയെന്ന് വരില്ല, പഴയ പോലെ ചെയ്യാൻ പറ്റിയെന്ന് വരില്ല. So that all is dexterity problem. When there is spasticity, you always have a dexterity. Dexterity എന്ന് പറഞ്ഞാൽ വഴക്കാണ്.
Oh,
കാര്യങ്ങളെല്ലാം ചെയ്യാൻ പറ്റും, വീക്ക്നെസ് വിൽ നോട്ട് ബി ദയർ, ബട്ട് ഡെക്സ്ചറിറ്റി, ആ വഴക്കക്കുറവ് ആണ് ഫസ്റ്റ് സൈന് യു എം എല്ലിൽ നമ്മൾ കാണുക. Okay, so vasculitis. Okay, so this is your differentials. Now these, based on this differentials, you will go to your examination.
okay, sir.
Okay, so go to the slides, please.
General physical examination. Child was conscious, oriented, and conversing well. Examined in supine posture. Attitude hands by side, shoulders adducted, extended at elbow, and palms facing up. Both lower limbs abducted at hip, extended at knee, legs laterally rotated, and foot externally rotated.
So
Vitals,
what is go to that slide. Go to that slide. What is your inference when you tell all this?
uh, basically, there is a weakness of muscle. So there is by the posture,
Child is hypotonic.
hypotonic. Yes, sir.
Child is totally hypotonic. Chest is just
Yes, sir.
flaccid and palms
Yes, sir.
up. The hip is externally rotated. And just child is just lying down.
Yes, sir.
Okay. Through this is okay. Next.
Vitals, pulse rate 86 beats per minute, regular rhythm, volume, character, no radioradial and radiofemoral delay, respiratory rate 28 per minute, saturation 99% in room air, BP 112 60 millimeter mercury, left measured in left forearm, supine position between 50th and 95th centile, temperature 98.6 degree Fahrenheit, no pallor, icterus, clubbing, cyanosis and lymphadenopathy.
I will stop you there. Can you explain why the vitals is important in this child?
Yes, sir. Vitals are important because in autonomic dysfunction, child will have either bradycardia or tachycardia. Respiratory rate, there will be shallow breath. Uh, so there can be
In
bradypnea. Sorry, sir.
autonomic
Respiratory muscle involvement. In respiratory muscle involvement,
so
there will be
first
bradypnea and shallow
autonomic
breathing.
full total. First go go systematic. First autonomic.
Okay, sir. In autonomic dysfunction, there will be tachycardia,
Then
bradycardia.
complete that whole autonomic and then go to the respiratory.
Okay, sir.
Okay?
There can be hypertension.
Important. Because
Yes,
we
sir.
are dealing with
Yes,
spinal
sir.
cord involvement.
Yes,
If
sir.
the whole spinal cord is involvement, there the sympathetic is thoracolumbar outflow.
Lumbar. Yes, sir.
The sympathetic is thoracolumbar outflow. The
Lumbar outflow.
parasympathetic is craniosacral outflow. So when the sympathetic system is involved, if it is some problem with the spinal cord involved, you
So, pardon? It's not audible.
have
Hello, sir.
hypotension.
Davidson, your voice is breaking. I think you can switch off the video.
Okay, you can have tension is involved. You'll have hypotension when the sympathetic is paralyzed.
Now it is okay.
Hello, is it okay?
Yes,
Yes,
sir.
yes. Now
Hypertension.
okay.
So when
Yes, sir. Yes, sir.
the sympathetic system is paralyzed, which is a thoracolumbar outflow, you will have hypotension. If it is a
Yes, sir.
GBS, you can have autonomic fluctuation depending on the stage. Autonomic fluctuation in GBS, and because of that autonomic fluctuation, you'll have urinary retention, bowel or bladder involvement in GBS,
Yes, sir.
because it is a nerve root also involved. Okay, so autonomic dysfunction can happen, of course, in porphyrias also. So there are multiple differentials, and based on it, our vitals is extremely involvement and respiratory paralysis.
Yes, sir.
So the patient, whether hypoventilation is there, why you are suspecting hypoventilation?
Respiratory failure.
Yes, respiratory, because truncal weakness is there, your intercostal is affected.
Yes, sir.
Your shoulder abduction is affected, so your diaphragm is paralyzed.
Yes,
So
sir.
it's a clinical emergency where child probably has to be intubated, depending on your clinical judgment. So hypoventilation, the patient will go into carbon dioxide narcosis or carbon dioxide retention. Okay, so vitals is extremely important in this child.
Yes, sir.
Okay, go ahead.
Anjali, one more thing. Davidson was pointing out the importance of the circulatory system assessment. The respiratory part it's not enough to mention the rate only, because there can be a weakness of the intercostals,
Yes.
diaphragm weakness. So
No
that is
paradoxical
you need
breathing.
to tell. And at this stage itself, better to say single breath count situation, because if there is a descending or ascending situation, especially when the cervical cord is involved, there can be especially shoulder diaphragmatic weakness can be there. So how much of the involvement of intercostal, whichever side is involved, diaphragm involvement is there or not, single breath count, all those things are important. And it's not merely enough to mention about the temperature. Unlike another general examination where you are just writing, like considering the respiratory rate, temperature, BP and all, these are relevant in a different way. It's not the fever what you are interested, but the temperature problems in the lower limbs. Is it any autonomic disturbance producing sweating and temperature difference in the lower limb compared to the upper limb? So it's not the fever part, but it is the autonomic disturbance part which you are assessing. So dryness or sweating, both are important, because in a spinal cord situation, there are a lot more other patterns: paraplegia in flexion, paraplegia in extension, and the pattern of involvement in the bladder and the position of the limbs. All those things are very important. So during the evaluation, there again one more thing: the BP seems to be 112/60, a little bit unusual. The pulse rate, pulse volume is a little on the higher side. Maybe it can be explainable by carbon dioxide retention, hyperventilation can lead to vasodilation, and pulse volume bounding situation can occur. So all those things are important in the vitals. One very important thing in a history also, there can be a situation of the paraplegia due to cardiovascular problems. Unrelated two things. One thing is a coarctation of aorta. Immediately after surgery, there can be a patient going on to paraplegia situation. And some other hemolytic disorders also. Rarely, those are things are important, relevant. Okay, go ahead.
Okay, sir.
Anjali, I'll stop you there as continuation of Purushottoman sir's things. The question for me: what are the bedside tests that will you look for respiratory failure or impending not respiratory failure? I'll correct myself. Impending respiratory failure. How are you going to do the bedside test?
Uh, Single breath test, single breath count test,
Okay.
and single breath holding test, coughing,
Okay.
and
A cough. Yes.
spirometry. And if a matchstick is available, blow a candle.
Okay. Blow a candle. Then another thing which is important: arm abduction. If the patient is above able to lift, I've been telling throughout. That is
Yes,
very
sir. Yes.
important. So
Yes, sir.
all PGs should try this. In the ICU, you don't need any pulse oximetry. You don't need any high funda multimeter for this. This has to be checked as soon as the child is in the casualty.
Yes, sir.
Yes. Continue, please.
Okay, sir. Head to foot examination, head normal size and shape, no dysmorphic facies, neurocutaneous marker, myopathic facies, rashes over face, no ptosis, strabismus, nystagmus, no membrane over tonsil pharynx, no oral ulcer, no mucocutaneous candidiasis, generalized lymphadenopathy, no glossitis, angular cheilitis, knuckle pigmentation, no bite marks, no spinal tenderness, gibbous, no rashes or bleeding manifestation, no joint laxity.
Yeah, carry on. I think we are running out of time also.
Okay, sir. Anthropometry, we have examined the child after day one when the child was able to stand. Uh, that's why we have taken weight
Okay.
and height. BMI is slightly overweight. Higher mental function, right-handed, conscious, oriented to time, place, and person. She had intact, immediate, recent, and remote memory. She conversed coherently and intelligently and was able to perform basic arithmetic correctly.
Okay.
Cranial nerve examination, olfactory nerve, normal, both right and left nostril. Optic nerve, visual acuity, color vision, tested normal. Should be ideally tested using visual acuity should be ideally tested by Snell and Stat. But due to the panic situation in the ICU, we just tested by the objects in the ICU. Color vision, ideally it should be tested by Ishihara chart. Again, due to the panic situation, we just tested by the object in the ICU. Field of vision normal, both right and left eye. Fundus normal. Oculomotor, trochlear and abducens, no ptosis, pupils round 3 mm, light reflex normal, direct and consensual, accommodation reflex normal, external ocular muscle movement, full both right and left.
All right. Carry on.
Muscles of mastication, palpable masseter, clenched teeth, both right and left normal. Pain, touch, temperature or face normal. Corneal reflex normal, both right and left. Conjunctival reflex normal, both right and left. Jaw reflex, jaw jerk normal, both right and left. Facial nerve, there is no deviation, and motor component sensory are normal in both right and left. Vestibular cochlear,
Okay.
Rene's is normal. Weber's is also normal.
Carry on.
Glossopharyngeal nerve and vagus nerve normal. Spinal accessory neck movements are normal. Hypoglossal nerve tongue in midline, no fasciculation. Motor system examination, bulk of muscle, there is no wasting of any group of muscle. Tone, upper limb and lower limb, there was found to be have hypotonia, both right and left. Power, upper limb, shoulder, flexors, abductors, adductors, right 2 by 5, left 1 by 5. Elbow, flexors, extensor, extensor 2 by 5 over right. Supinator, pronator 1 by 5 over right. And flexors, extensor, supinator, pronator over left 1 by 5. Wrist, flexor, extensor, abductor, adductor 2 by 5 on right. And left also 2 by 5. Hand flexion of fingers 1 by 5, right, but left only 0 is there. Extension of fingers 0 by 5, both right and left. Lower limb, hip flexors, extensor, adductor and abductor 1 by 5, both right and left. Knee flexors, extensor, right 2 by 5, left 1 by 5. Ankle dorsiflexion, plantar flexion 1 by 5, both right and left. Inversion, eversion 0, 0. Neck muscle, flexors, rotators 4 by 5. Reflexes, plantar was absent, both right and left. Superficial reflex, deep tendon reflex, triceps, biceps, supinator, knee jerk and ankle jerk was absent, both right and left. Cerebellar signs, there is no nystagmus, dysarthria, scan and speech. Sensory system, light touch.
Why you didn't do? I'll stop you there. Why you didn't do the rest of the examination, cerebellar system?
Because child had weakness, so was unable to
Yes.
rise arm and legs.
Correct. So whenever you have so much of weakness, you need at least 3 plus or more power for cerebellar system examination. So you need power of more than 3. So without that, you cannot do cerebellar. So that's rightly told. And coming to this abdominal uh, test, was
Abdomen.
there any? Yes. Suppose I say that this sensory. Have you come to the sensory level? No, sir. So you're coming to the sensory. Okay. Yeah, sensory. You can tell me. Please continue.
Okay, sir. Sensory system, light touch, normal, both right and left. Vibration, normal, both right and left side. Pain reduced in supraclavicular area. Thorax reduced. Abdomen upper reduced, lower normal. Temperature also reduced in supraclavicular area. Thorax reduced. Abdomen upper reduced, lower normal. Lower limb, the child perceived pain and temperature normally only. Pressure, both right and left, normal. Uh, Cortical sensation, stereognosis, 2-point discrimination, graphesthesia, tactile localization, right and left, normal.
Okay. So now you have a sensory level, you have quadripartic, autonomic, the respiratory system is normal.
Yes,
Not
sir.
respiratory, cranial nerves are normal. Okay. So sensory is a very, very important and tricky for examination. So in this child, when you examine, it is very important to examine from dullness to normal side.
Yes, sir.
So you know that somewhere in the C5 region is probably it is. So let me ask you, Anjali, for a child, for this child who came directly to you, what would the first three examinations clinically you will be doing? This child has come with you with a history. You're going to examine this child. What are the first three system examinations that you will do?
Uh, in CNS.
Anything. Child has come to you, dropped in front of you. You are on duty. What are the first three system examination that you're going to do? What all you're going to do?
Uh, in CNS system,
No, 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 Anjali.
uh,
The patient is not a neurological. Look at the patient in toto. The patient comes to you. What are the first three things that you're going to look for?
airway, breathing, circulation.
Okay, first is whether the child has come to you paralyzed. You don't want the child to aspirate. You don't want the child to go to respiratory failure. So first is respiratory.
Okay, sir.
So once you assess that, the first thing that would be the order of preference. First, you assess that because otherwise the child will die out of that. That is the
Okay,
first
sir.
thing. Second thing is second,
CNS.
you want to see whether okay in CNS what you will be doing first.
Uh,
Here you know it's a descending paralysis. You want to know whether it's a spinal cord thing or is it outside the spinal cord thing. Simple as that. Because if it is GBS, the first investigation that you're going to do is a NCV or NCS study. If it is a spinal cord thing, the first investigation that you're going to do is MRI.
MRI.
Now, the only thing that is going to help you right now will be a sensory level.
Yes, sir.
To understand. So I looked at the respiratory component of the child, whether the child is fit for my sensory. Here you look at the sensory system, which is a very tricky one, which can take easily 5 minutes. And in that 5 minutes, child should not aspirate, child should not, go into respiratory arrest. So looking at the respiratory, of course, the autonomic also. And first, you try to localize whether you are getting a sensory level. If you're getting a sensory level, then you clinch the diagnosis that it is a spinal cord problem.
Yes, sir.
Okay. So, always when a patient comes to you, you have to give preference and you have to do examination based on your clinical acumen. Just because your CNS examination says higher mental functions, cranial nerves, motor, reflexes, sensory, then gait, you have to
C for respiratory.
use your common sense and tweak it according to the situation. As a
Yes,
PG,
sir.
that is very important.
Yes,
Okay,
sir.
so now you have a sensory level. Okay, let's wind it up. It's almost 9.
It's
Let's
okay,
go
Davidson. In that
down.
sensory part, Anjali, what is a
Yes,
very
sir.
interesting thing about the sensory part? Pain and temperature is only involved, and that too, where is it involved? Supraclavicular bilaterally, thorax bilaterally. What about the upper limb?
She was able to perceive, sir.
Upper limb fingers and in the
Yes,
area
sir.
of
Yes, sir.
C5, C6, C7, C8, that part it is
Yes, sir. She was able to perceive.
pain and temperature is perceived.
Yes, sir.
Pain and temperature is lost only in the supraclavicular thoracic. Which segments are they representing?
Uh, C
Supraclavicular, thoracic, and abdomen.
supraclavicular C3, C4. Thorax T1 to T4.
Abdomen also reduced in the upper
Abdomen also,
abdomen also.
upper abdomen.
Pain and temperature only is affected there. About the
Ye-
touch is perceived there.
Yes, sir.
What is that pattern of sensory involvement suggest? In the lower part bilaterally, it is spared. Okay.
Anterior.
And the pain and temperature is only involved. It is bilaterally symmetrical. It's in the few segments only. So which part of the spinal cord, which area of the spinal cord will give that sort of a pattern of the sensory, and is that important?
Lateral.
ഭയങ്കരമായിട്ട് അന്വേഷിച്ചെന്ന് പറയണം, സിസ്റ്ററി വിളിക്കുമ്പോ പറയണം എന്നൊക്കെ.
Anna. Okay, go ahead. Davidson discussing.
So I
Lateral
was
part of
telling
spinal
about.
cord. Yes, sir.
So the pain and temperature crosses over. My right hand's pain and temperature comes to the right anterior part of the spinal cord and then crosses along to the central canal and goes up. The left hand's pain and temperature crosses along the central canal and then goes up. So when you say bilaterally and pain and temperature is affected first and lower it is normal, that means bilaterally the crossing fiber is
Crossing
involved.
fibers. Yes, sir.
That means the central canal, the both crossing fiber are passing near the central canal. So when there is either a tumor in the central canal or there is a syrinx, some pathology in the central canal will produce it is a suspended differential sensory loss. We call it a suspended sensory
Sense.
loss that is seen classically in syringomyelia.
Syringomyelia.
Okay, because only pain and temperature is affected at that level. Above that level and below that level, it is normal. Okay, so that is what when you tell pain and temperature is only affected, this could be possible. And of course, when you have a spinal cord involvement, the patient might not, if you don't very meticulously examine if it is a dull pain, it's not a complete no, like numbness doesn't set in, you might not get a proper localization. You got a sensory level, yes. So if you just touch the right side of the chest and left side of the chest is both both same, yeah, both dulling will be equal unless you compare the chest to the upper neck.
Okay, sir.
So that is also, the sensory examination is a very tricky one. Even experts can go wrong. Patient can confabulate. So now let's assume that you have a level. Yeah, let's continue this. So now you have a level, you have quadriparetic. I think rest of the examination is normal, right? Now you have a sensory level and quadriparetic without involvement of the cranial nerves. So, and somewhere in the C3, C4
Cervical.
level, you are getting it.
Yes, sir.
So, so what will be your first differentials? Do you have your differentials?
Yes, sir.
So mental signs, nothing. Other systems are normal, right?
Yes, sir.
Okay, you can go to your differential straight.
Demyelination disorders will come to the first group.
Okay. Tell.
Like transverse
Explain
myelitis.
your differentials. Tell me why your explanation is there.
Um, because here spinal cord is involved.
Because the first, it is you since you have a sensory level and it's bilaterally symmetrical.
Yes,
The
sir.
odd point here is bowel and bladder is not involved.
Not involved.
Okay, it depends on the degree of the spinal cord damage. Your bowel and bladder might present very early or after a couple of hours or sometimes after 24 hours. So now you have a bilateral symmetrical, almost symmetrical weakness motor with sensory level. So it is spinal cord until proven
Spinal cord.
otherwise.
Yes, sir.
Okay, so your this thing GBS all will come down because you are not get in GBS you don't get a sensory level. You get sensory
Sense.
symptoms, but you don't get a sensory sign in GBS. That is a classical teaching, and the descending type of GBS variant is there. And GBS usually, when the GBS is affecting the upper limbs, usually the cranial nerves, bulbar,
Yes,
facials
the facial is
is
involved.
commonly involved. That is usually involved. So GBS goes down the line. So it is a spinal cord thing. Now, acute onset spinal cord things are a vascular or a demyelination.
Yes, sir.
Okay, so vascular, what we have is a anterior spinal artery
Spinal
thrombosis.
artery ischemia.
So when anterior spinal artery is involved, what happens? The anterior spinal structures are affected, and
Yes,
the
sir.
posterior spinal structures are spared.
Spared.
So one test that you do apart from the motor system examination, where definitely weakness will be there, one sensory examination that will you do is to look for the vibration.
Yes, sir.
You take the tuning
Dorsal
fork, put for the
column.
vibration, yes, and vibration, because in anterior spinal artery thrombosis, the dorsal column is spared. Vibration
Spared.
goes to the dorsal column. You put on the malleolus, and you know that the vibrations intact, then that differentiates, that clinches the diagnosis for anterior spinal artery thrombosis. That is one thing. Then AV malformation, arteriovenous malformation, the whole spinal cord ischemia will be there. And what will be you look in the spinal cervical spine? You look for a bruit.
Brewing. Yes, sir.
You look for a bruit. Okay, that should have been told. Did you tell that in the
Yes, sir. In
examination,
the
general
skull and spine.
examination? Okay, fine. Let's. So it could be a Can you come to your differentials? So vascular event you tell, and spinal cord. Spinal cord ischemia. That is anterior spinal arteries. Vasculitis could be a cause. AV malformation and demyelination. It is a descending type. So the very characteristic of this is a descent. So it could be demyelination, could be anything of the demyelinating, like neuromyelitis optica, MOG, or multiple sclerosis. Okay, and lastly, GBS variant. So
Yes, sir.
what, depending on this, what would be the child is respiratory, okay, stable, let's keep it. What will be the first investigation that will you be doing in this child?
Um, basic blood investigations.
Agree.
Airway. First, we should see for airway breathing circulation.
Just 1 minute, Anjali. In the divisional diagnosis, the last thing, the GBS variant,
Yes, sir.
it's almost out. In fact, by the time you are getting a tract type of sensory loss which is persisting, it is documentable. In the case of peripheral demyelination and all, there can be some transient period of sensory or bladder disturbance. But in a case where there is a documented this type of sensory loss, That is a pain and temperature in the suspended bilateral symmetrical form and all clearly anatomically localized, it is within the parenchyma. Then only this type of sensory loss will occur. That almost rules out a peripheral demyelination. Of course, that when at the end of your history you were considering demyelination peripheral as one of the most important. Now
Yes.
it comes the peripheral are totally out and it is in the spinal cord, out of which different diagnosis, as you said, is right. You need to consider demyelination, vascular, different types of all everything. Okay, go ahead.
Okay, sir.
So what test will you be doing, Anjali? Yes, the blood certain. One test that you have to do that will help in the child's treatment.
So basic investigation we should do, uh, and then we should do MRI.
Yeah, MRI will help in
Yes,
the child's treatment. That will be the most important to
yes.
look for.
MRI
Look if
brain
it is a
body
tumor.
spine.
If it is a tumor, it will be the spine. It will be the spine. Your area of interest is right. MRI spine with contrast. Because if it is a tumor, you have to immediately call the neurosurgeon because the child is dying.
Yes, sir.
Weakness is progressing. OI. If it is demyelination, then you have to start on the appropriate treatment. If it is a AV malformation, then you'll have to involve the concerned surgeons or the interventional
Yes,
radiologists,
sir.
depending on what it is,
Yes, sir.
or whether it's a ischemia. So MRI spine is the cornerstone to
Yes, sir.
have
We have done
the
an
different
MRI.
etiologies. Okay.
Yes, sir. We
Then
have done a
yes, your bloods will
MRI.
and your bloods will help you to say whether it's vasculitis or any other systemic association is there or any associated infections was there or not, or TB pot spine was there. Yes, but MRI spine, without that you are losing time for this child
Yes, sir.
in terms of the treatment. So MRI spine was done. So
Yes, sir.
Purushottam
MRI.
sir, is there anything you want to add, sir?
No, I'm interested to see this the MRI image. You got that image?
Can you show the MRI image?
Yes, sir.
Can you explain that?
Here we have hyperintensity extending from C2 to T1 area, longitudinally extending, sir.
T1 ആണോ കുറെ കൂടി താഴേക്ക്
T2.
പോകുന്നില്ലേ
T2, sir.
Okay. Okay.
Anjali, carry on.
Okay, sir. Also, we have done a contrast. Again, we have done a CSF study, which was normal. Glucose was 60, the GRPS was around 120, protein 23, WBC 2, RBC nil. Diagnosis, coming to the diagnosis, demyelination disorder, longitudinally extending transverse myelitis, including C2 to T1 segment.
So, in CSS for a demyelinating disorder, what would be the CSF finding?
There will be slight pleocytosis, or it can be normal also, sir.
You can have a pleocytosis. Yeah, you may be normal. Another thing is that since it's an autoimmune phenomenon, demyelination, you may have a protein elevation.
Protein,
You may
increased
have,
protein.
not always, you
Yes, sir.
may have a protein elevation. Okay. Because immunoglobulins are being formed
Yes, sir.
intrathecally. Intrathecally means inside the CSF there is more of immunoglobulin. So the CSF protein may be elevated. So where you have a normal glucose, maybe like 5 cells, and protein is say you are getting in 80s or hundreds, then think that there's a immunological or autoimmune or a demyelinating phenomenon.
Inflammatory.
Okay.
So,
Did you do
Then
the
of course you
VP, P100 visual?
sir,
Anjali,
pardon? Pardon, sir.
Did you consider multiple sclerosis also or a demo? What are they?
She's it's a female child. There is more possibilities there, but we didn't send for
what was it,
oligoclone and OCB. We didn't send, sir.
Anjali? Before that, how was the MRI brain? You will get the answer of sir
MRI brain, there is
from
no
that.
ovoid. Usually in MRI brain, there will be ovoid uh, structures. Here it's normal,
Did you
sir.
get any?
No.
Usually in multiple sclerosis, you will have dissemination in time and space. You
In
will
space.
have active lesions and non-active lesions. For such a large involvement, spinal cord involvement, there will be definitely some brain lesions for a multiple sclerosis. And that is why you will have optic neuritis also. That's why sir
Yes, sir.
wanted to know whether you have done a visual evoked potential. Visual evoked potential will be abnormal in optic neuritis. That is what sir
Yes.
was trying to ask.
No, sir. We didn't do.
Okay.
Hi.
Next, I think Purushothaman sir
Continue.
left.
You did
Okay.
continue with
Okay.
the
Yes.
management part.
How did you manage?
Uh, Child was started on injection methyl uh, 30 mg per kg per day, and IVIG infusion also, sir. After 1 day of injection
Continue. Continue.
methylprednisolone and IVIG, child's power slowly improved. She was able to lift arm above head, plantar become extensor, knees are and ankles are brisk. On day
All
2,
right.
child was able to walk, started on physiotherapy. On day 8 of admission, child developed urinary retention, was catheterized.
All right. So now the bladder is involved.
Yes, sir. An injection
So
methylpred was
what?
given for 5 days and then tapered to oral prednisolone. Serum NMO MOG was negative, sir. And as the bladder involvement was there, we again did an MRI spine, which showed resolving myelitis.
Let's from this. What do you look? You have given an intervention for the disease,
Yes, sir.
and within how many days the child has improved?
Within a 1 day, child was able to lift
So,
arm above
so
head.
after 24 hours, the child
Yes, sir.
has improved significantly.
Yes, sir.
So, what do you think is the pathology here? Yeah, MRI report, you have a lesion. Okay, I say this lesion could be a demyelination. I say this lesion could be a ischemia, a large spinal cord ischemia or thrombosis. Uh, I say this could be a infection,
Yes,
which
sir.
is producing a myelitis, an infection-related myelitis. So there are three things. Should be a vascular thing, or it could be infective thing, or it will demyelination. And after 24 hours, the child has improved significantly. So out of this three, what do you think is a possible etiology, depending on the response to your intervention of steroids and
Demyelinations.
IVIG? Why demyelination?
Because of the rapid improvement.
Yes, correct. A thing which improves significantly after 24 hours, a child who was lying down and improving so much is very, very, very significant. But usually after 48 hours, there is significant improvement. If it is a spinal cord ischemia or AV malformation,
It could take.
uh, yes, it is a ischemia of the spinal cord. The spinal cord is dead. So child will not just get up, child will not just lift. It will take weeks. Okay. And if it is a myelitis due to infection, definitely the parenchyma is involved. To some extent, that child also will not respond so dramatically to your steroids and IVIG. So most probably with your intervention, child has improved, means it is by the response, it looks more of a demyelination.
Demyelination.
Now, what has caused this demyelination? Your workup is negative, but still it is some kind of a demyelination because of the dramatic improvement.
Improvement.
And your repeat MRI is showing resolution.
Yes, sir.
That's wonderful.
Can you show that MRI picture?
Yes.
Repeat MRI.
Can you show the lesion in the first MRI and resolution in the second one?
This was the lesion taken on 6th of August, and in 18th August, it's resolved.
You can show the videos if you have.
So can I continue?
Yes,
Yes,
you
yes.
can show.
Okay, sir. On day 20 of admission, child was able to walk. And also upper limb also. Weakness
Alright, very
results.
good.
And there was mild weakness in the distal group of muscle, and she is on physiotherapy.
Bladder improved.
No, sir. Still, she is catheterized.
Catheterized. Okay.
So any input from the source?
That was an excellent discussion. That was a case presentation. Anjali, all the
Yes, sir.
postgraduates should go through the basic neuroanatomy of the spinal cord, the different tracks and localization. This is one of the classical situations. You are not systematically we analyze the different possibilities how to picture the spinal cord localization, and that there are different types of spinal cord involvement. So for discussing that, the neuroanatomic part very important. The localization, all of you should read the localization neurology from maybe braces will be much helpful for that, and should hear other clinical discussions also. Excellent discussion, Davidson. Sanjeev, any more
Thank you, sir.
input from you?
Good evening, sir. So it was a very nice discussion. Actually, we wanted to present this case because this child was financially very weak and they were very reluctant for even the initial investigations. And they were brought with these symptoms, and from outside, they were come with a report of nerve conduction study because keeping that possibility of GBS, and they were given that nerve conduction is affected and it is consistent with GBS. But the clinical picture was little different. So we went ahead with that MRI imaging, and we wanted to highlight that importance of prioritizing the investigations depending on the clinical evaluation. That's all, sir.
Was there any small muscle weakness or wasting at present? No, bulk is there. Anjali?
Presently they are undergoing physiotherapy. Initially, the small vessels were reluctant to improve, but because with that all these balls and all other some physiotherapy, this thing, child is improving. Now child is able to draw and start writing also. It's steadily improving.
Next time, Sanjeev, avoid this room for presentation because this is near the casualty. Yeah. Anjali presenting. Anjali, where are you presenting from? Which room? It is near the casualty. Ambulance and
No, she is the ward only, no? The ward is Anjali.
Sir, pardon, sir.
ആംബുലൻസിന്റെ ഒച്ച എവിടുന്ന കേൾക്കണമെന്ന് ഞാൻ ചോദിച്ചത് പ്രസന്റേഷൻ സമയത്ത് മുഴുവൻ അല്ല എന്റെ വീട്ടിൽ നിന്നാണോ അല്ല അവിടെ നിന്നാണോ? അവിടുന്നായിരിക്കും.
അഞ്ജലി വാർഡിലെ റൂമിലല്ലേ? വാർഡിലെ സൈഡ്
ICU,
റൂമിലാണ്
sir.
അല്ലേ? ICU ആണല്ലേ? ഓ ICU.
വേറെ
ICUയുടെ
ശബ്ദം
അകത്തേക്ക് ആംബുലൻസ് വരില്ലല്ലോ അല്ലേ?
ശബ്ദം.
ഇല്ല, സ്ട്രെച്ചറിലായിരുന്നു സർ.
ഓക്കെ.
താങ്ക് യു. പാർവതി മാഡം, എന്തെങ്കിലും എനി മോർ കമന്റ്സ് ഫ്രം യു? മാഡം അവിടെ.
Nice discussion. Nothing to add. Very nice discussion.
Thank you, Davidson. Thank you, Anjali.
Thank you.
Both of you.
Thank you, David.
I,
And
I want to add, sir.
Ah.
Thank you very much for Davidson. And I would like to
Thank
add that Davidson is our student. He did his MBBS from our first batch of MBBS from Jubilee. And then only
Oh,
he
very nice.
completed MD. And we are very proud to have him as a faculty. Now he is working in Aster. Thank you, Davidson. Thank you very much.
Thank you, sir. Thank you. I'm very happy that I was be able to be associated with this, and from a case from Jubilee, it's very close. I mean, Trishur has been always very close to me because majority of my medical learning is from Trishur right after my 12th.
Very
Thank you,
nice.
everybody.
Very nice, anyway. Very nice.
മോഹൻദാസ് ഉണ്ട് അവിടെ. മോഹൻദാസ് ലെഫ്റ്റ്, ഐ തിങ്ക്. ഷിജി ഉണ്ടോ? ഷിജി, ജസ്റ്റ് ഫോർമൽ വോട്ടിംഗ് താങ്ക്സ്.
Yes, sir. Yes, sir. Okay. Respected senior members of the forum, Purushothaman sir, dear Sanjeev sir, Dr. Davidson, Dr. Anjali, and everyone. Dear Parvati madam and everyone, I thank the team for this excellent presentation. It was wonderful. And thank you everyone for the patient listening. Thank you. Good night.
ഗുഡ് നൈറ്റ്.
Good night.
Thank you.
Thank you. കുഴപ്പമില്ല.